Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
All right, hello everybody. I'm JP Hong. I'm a plastic surgeon working in Seoul, Korea at Asan Medical Center. My main area of focus is lower extremity reconstruction and also lymphedema surgery. This is presented by the LE&RN online symposium. And it's sponsored by many leading industries in our field. And I do believe that networking together and collaborating together with these important companies help us to innovate and to push our field further. LE&RN sponsored information is provided for use for you in consultation with your healthcare professional, and it's not meant to take the place of healthcare or services you may need. Please see your primary healthcare provider about any personal health concerns. All right, so welcome back again, everybody. I'm JP Hong. I just want to quickly remind you, for any questions you may have, please use the Q&A box. And at the end of the lecture, hopefully I'll be able to answer most of your questions. As you all know, lymphedema is not really something new. It's been around more than 4,000, 5,000 years ago. And the first documentation of lymphedema actually goes back to the Egyptian period. Now, to make things very simple, lymphedema is basically a broken balance between formation and accumulation of lymphatic fluid versus the clearance capacity. So if the clearance capacity drops, then the fluid accumulates, or if the fluid formation increases and the clearance capacity stays the same, you still have more fluid in the extremity. So keeping that in mind, I think really makes it simple for you to understand what lymphedema is. So let's take a look at this lymphedema patient here, where the patient underwent a cancer surgery, removed the nodes, and because the clearance capacity, because removal of the node makes an obstruction in the lymphatic pathway in the pelvis, the clearance capacity went down, even though the fluid formation is normal, because it cannot evacuate, it cannot be drained, it starts to accumulate. And what happens if the accumulation continues? Eventually, it starts to drip out of the skin. And this is the lymphatic fluid draining out of our normal skin. So what do we do since 4,000 years ago to help these patients that have these kind of drainage problem or problem of excessive accumulation of lymphatic fluid? And the basic idea was, because the lymphatic fluid accumulates mostly in the fat, by removing the storage capacity, we thought that we'll be able to control lymphedema. And that's what debulking surgery or removal of the fat and skin grafting, such as Charles procedure or liposuction, aims to do. And however, that kind of surgery, although may improve some of the symptoms, because the draining capacity still remains very low, the fluid accumulates quickly again, unless you remove the entire fat. And this is why we need more physiologic procedures to increase the drainage capacity. And this is what we'll be talking about today, which is increasing the capacity by creating an early shunt of the lymphatic fluid draining out to the vein, distal to the obstruction, and also replace what is missing, such as lymph node flaps into the place where it has been removed. So that's basically the idea of lymphatic surgery. And as you all know, lymphatic vessels are all around in our body, like the artery and veins. The lymphatic vessels are all around. And ultimately, the lymphatic vessel drains to the subclavian vein just before it enters the heart. So there is a natural shunt or natural drainage system of the lymphatics going into the vein. And the idea is clear. You ask, where is the obstruction? And then you go distal to the obstruction and create that bypass so the obstructed lymphatic fluid can drain into the vein early, and then thus prevent the fluid from accumulating in the fat of the extremities. Now, here's a very good example of understanding the obstruction and bypass principle. This was a 3-year-old patient with a congenital agenesis of the kidney, was a congenital problem of where the kidneys does not exist, and the patient underwent hemodialysis since birth. Now, by doing that, they had to change the port several times, and that caused a rupture of the subclavian vein where the lymphatics drain naturally. So the obstruction occurred in the area of the subclavian vein, and the fluid started to accumulate, and ultimately it started to drain into the pleura, which is covering the lung, and is causing a problem called chylothorax, and it makes it very difficult for this patient to breathe. So what do? We create a bypass distal to the obstruction in the lower extremity, and you could see really quickly that the chylothorax, or the accumulation of fluid in the pleural space, started to decrease, and then we removed the drain, and the patient was able to breathe normally. So understanding the idea of where is the obstruction, creating a shunt distal to the obstruction is the key to creating a more physiologic solution to the problem of lymphedema. I think the basic question that we all ask is, since there is no concept of cure for lymphedema, how can we improve the quality of life? And of course, that is addressing or reconstructing the physiologic properties of the lymphatic system. So today we're going to be talking about what are the recent innovations and the evidence behind this kind of lymphedema surgery. And as I just mentioned before, the two major physiological approaches are creating a shunt, lymphovenous anastomosis or lymphovenous bypass distal to the obstruction. And another way to create a bypass is we came out with a new method of connecting the lymph node to the superficial vein. So we call this the lymph node to vein anastomosis. And the final method is replacing what is missing by adding the lymph node in a flap with a well-vascularized fat and lymph node into the place where it's missing, such as axilla or the groin. And that's been one of the ways to approach lymphedema surgery. Now, if you look at the recent history of lymphedema surgery, this was first started the research early in the late 60s and the 70s. And they started to do lymphovenous bypass. But why hasn't become mainstream surgery for lymphedema? Is because the degeneration of the lymphatic vessels occurs from proximal to distal. And back then in the 70s, they only had the right tools to do anastomosis for larger lymphatic vessels, which are located near the groin. And when they opened the groin, sometimes they saw functioning lymphatics, but most of the times they saw already degenerated lymphatics. And even though they create a bypass, the lymphatics are already degenerated, sclerosed. And this is why it didn't work a lot of the times. And that's why the art of creating this lymphovenous shunt was abandoned quite early. So the reason why that it didn't work was that they didn't have the proper ways to diagnose or to actually identify where the functioning lymphatic vessels were. And this is why it lost its popularity early in the introduction of the lymphovenous anastomosis. But now, one of the biggest innovations that we have made in lymphedema surgery is the tool to identify functioning lymphatic vessels. And the main two modes, in our opinion, are the ICG, indocyanine green. You inject it in the web space. It's quickly uptaken by the lymphatic vessels. And once you see this under a infrared light, you see that there's clear lymphatic vessels traveling in these, traveling in our legs or in our arm. And once you see that, this is where we make the anastomosis. However, one of the biggest limit for the ICG is the penetration only occurs to around 10 to 15 millimeters. So that's 1.5 centimeters, a little bit over half an inch. But a lot of the times we see severe patients that are already has edema, swelling, more than 1 or 2 centimeters, more than an inch. And the ICG doesn't give us enough information. So the next modality that really made the next biggest breakthrough was using an ultrasound. And as we compared multiple modalities that are used to identify functional lymphatics, in our mind, the ICG is the easiest. And if the patient is a little bit more severe or more advanced, in that case, it is the ultrasound. So we actually did this study looking at more advanced cases, and the positive detection rate for relatively advanced lymphedema turned out to be the highest in the ultrasound compared to the ICG and MRI. However, in the early stage, it doesn't matter what tool you use, ICG remains to be the easiest way. And looking at leading to successful conversion of surgery, ultrasound, of course, in more advanced cases, really helped us to identify where the functional lymphatics are exactly and how to connect them into to the vein. So here's a quick video example of what the ultrasound is able to do. In this first patient here, the patient is less advanced, and you could clearly see the ICG being uptaken in the foot. And of course, with the ultrasound, you're able to also identify lymphatic vessels, as you can be seeing here. Another advantage that the ultrasound gives us is that it also allows us to map where the nearby vein with the good matching diameter is. So this also helps to pre-plan the surgery and make it as simple as possible. Now, in this patient with a more advanced stage 3 lymphedema, you could see that the ICG is not actually being seen because of the increased swelling of the arm. This is also called the stardust pattern. But does this really mean that there's no functioning lymphatics underneath the skin? And this is when the ultrasound comes in. And unfortunately for this patient, or around 8% of the stage 3 lymphedema patients, there is actually no more sizable functioning lymphatics. Here we just see vein, and we don't see any lymphatic vessels at all. So in this case, the patient is not indicated for LVA. Now, in this patient, also with severe swelling, even though the ICG is not seen, using the ultrasound, we could actually see a functioning lymphatic vessel and a nearby vein. So in this case, we're able to map this functioning lymphatics, even though it's not seen by ICG, and able to proceed in doing a very nice lymphovenous bypass. And as you can see, as the lymphatics undergo higher pressure, it starts to build thicker walls, and ultimately it becomes completely sclerosed. And this is why 8% of stage 3 lymphedema in our practice is not able to, we're not able to do physiologic surgery using the lymphovenous bypass. So the ultrasound becomes really handy to detect functioning lymphatics in these more advanced patients. Now, you can use regular ultrasound, but the frequency has to be at least from 10 to 20, so at least 18 to 20 megahertz, using a high frequency ultrasound. However, using a higher frequency ultrasound, which is called the ultra high frequency ultrasound of 33 megahertz, really helps you to quickly and early detect if there is functioning lymphatics. So there is, yes, a special type of ultrasound, a higher frequency ultrasound called the ultra high frequency ultrasound, and this is actually used to easily detect functioning lymphatic vessels. So the ultrasound in our hands, especially for the patients who have more advanced lymphedema, we now have clear evidence that the ultrasound assists us in finding not only functioning lymphatics, but the largest functioning lymphatics, which makes the surgery much easier and also helps us to identify our nearby matching diameter vein and allows us to exactly pinpoint the area of incision, saving surgical time. Now, the downside of using the ultrasound is, of course, there is a learning curve involved, and the surgeon has to be well trained and finally able to use this modality. So the biggest innovation in my mind for modern lymphedema surgery is the introduction of the ICG, followed by the use of the ultra high frequency ultrasound. And I think that has made clearly lymphedema surgery easier. Now, the interesting thing is that there's still a lot of innovation going on in imaging, such as this type of laser tomography or photoacoustic lymphangiography. And hopefully we'll be seeing more of these innovations that allow surgeons to easily, quickly detect a functioning lymphatic vessel. Now, the second innovation, and of course we mentioned this, is the physiologic surgery itself, and it's lymphovenous anastomosis, doing bypass distal to the obstruction and hooking up a large superficial vein to a functioning lymph node. We call it LNVA, and obviously the lymph node flap. Now, this is where the concept of supermicrosurgery comes in, especially for the lymphovenous anastomosis. The definition of supermicrosurgery is the surgeon's ability to now perform surgery in vessels as small as 0.3 to 0.5, which are the average size of the lymphatics. So basically, the concept of supermicrosurgery is successfully manipulating vessels of less than 0.8 millimeters. Now, why is this significant? Because we didn't have the right tools before, we didn't have the right machines before, and we didn't have the ability to identify functional lymphatics before. And this is why the early lymphovenous bypass in the groin area was so unsuccessful. But when you go distal, because the degeneration of lymphatic vessels occurs from proximal to distal, as you go distal in the wrist or distal in the ankle, the chances of having a more functional lymphatic vessels are higher. However, the downside of distal lymphovenous bypass is that the lymphatic vessel also becomes very, very small. And this is why introduction and using the supermicrosurgery allows us to have a better result, is that because when you go distal, the chances of having functional lymphatic vessel becomes higher. And nowadays, modern tools from Crown Joon or ultra fine forceps, microscopes with mounted ICG with higher magnification, and of course the ultrasound makes all this possible. And I think this is the biggest innovation. Now, what is really exciting is that a lot of questions that I get is, how much experience do you need to actually become a surgeon doing a supermicrosurgery easy? And my answer would be, it's not. It takes a very long learning curve of at least few hundred cases of microsurgery, a few years at least to train, and then you're able to acquire these fine skills to go under 1 millimeter and do this kind of supermicrosurgery. So the truth is, not many surgeons are able to get to that level of really routinely, comfortably performing this kind of supermicrosurgery. And that's where the idea of using a robot where it scales down the movement and allow any surgeon with some concept of microsurgery to perform these ultra fine procedures really came into light. And one of the pioneers in this field is this gentleman, Marco Innocenti from Italy, who has really pioneered in the science of using these small robots and allows increased dexterity that the human hand does not have. So as you can see in this quick table here, the Simani robot has motion scaling of 7 to 20 times, and it doesn't have any tremor. And the technical capabilities are just beyond normal dexterity of the hand. There is, of course, a learning curve, but after few cases, you're able to perform at the same level with any supermicrosurgeon, and that's the most exciting part. So what we also notice is that the actual learning curve for the robot is almost the same in the experienced microsurgeons compared to the novice microsurgeons. And the success rate is almost the same as well. So, and if we look at this electron microscope comparing the hand to the robot, you could see how the robot has regular spaced, nice, everted anastomosis, and most of all, no micro ruptures. And I think this is what makes this technology very exciting, allowing every microsurgeon to do this. So if you look at this quick video here, in the left, we're doing a lymphovenous bypass, and on the right, we're doing a 0.6 millimeter vessel anastomosis. And look how stable the robot is compared to the human hand. So I think this video tells the whole story. And so what does this mean for patients around the world? It means that Now, potentially, any microsurgeon near your home or your city has the ability to perform this type of super microsurgery or lymphovenous bypass without having to travel a long distance to find your nearest lymphedema surgeon. So there is a potential democratization of the surgery using this robotics, and I think this is really one of the most exciting innovations that we have seen in microsurgery world in a very long time. So let's go back to talk a little bit more about the evidence, the latest evidence in lymphovenous anastomosis. So there was a lot of mention in selecting the ideal lymphatics, and there's a lot of evidence showing that now we have the tools to identify, to discard non-functioning lymphatics, and not only that, to find the best functioning lymphatics, which is dilated, which is deep, located in the deeper fat and usually anatomically larger, and use these kind of lymphatic vessels to do the anastomosis. And here again, the deeper you go, the deeper fat you go, we're able to find larger collecting lymphatic vessels, which makes the anastomosis much easier. So the key is finding bigger, better function lymphatics, and that's what we're able to do. But there was not many research in talking about the ideal vein. What is an ideal vein? So if you think about this, a quick a recap of how lymphovenous anastomosis work is that in the normal body, the lymphatic pressure is very low, lower than the vein pressure. So, but once there's an obstruction in the lymphatic system, obviously the lymphatic pressure is going to go way up, all the way to 200 millimeter mercury. And when this happens, it goes above the pressure of the vein. And this is why once you connect the lymphatics to the vein in the distal leg, because of the pressure gradient, high pressure lymphatic drains to the low pressure vein. So if you think about what is an ideal vein, it's a vein with minimal pressure. And how do you determine minimal pressure? Is by looking at the vein when we cut it and making sure that there is not big backflow. If there is backflow, that means increased venous pressure, and that may not be the ideal way to connect the vein. So the key here is identifying veins with a lower pressure. And in order to do that in the upper arm, in the upper extremity or the arm lymphedema, what we also found out is that by removing the previous scar in the axilla, and because the scar is compressing the axillary vein, by removing the scar, we're able to decompress the axillary vein, as you can see here. And then this allows the overall lymphatic venous pressure to drop in the arm. So what we found is that especially in advanced lymphedema cases, when you see this kind of compressed axillary vein, it is very important to decompress, remove the scar completely, because it helps to maximize the pressure gradient. So that is one way to do it. But what about selecting the vein in the area of the anastomosis, in the ankle or in the wrist? Is you have to find the vein with minimal backflow. And to do that, what we found out was that if you use a branch from a larger vein, there is always a valve that prevents the backflow of the vein going distally. So the key here is to identify a vein that has a valve and doesn't have any backflow, which really allows the lymphatics to drain much more better. So here's an illustration that you could see when you use this kind of branch from a larger vein. It has a valve and there's no backflow of the venous blood into the lymphatics. But instead, because there is a valve, the lymphatics drains quite easily into the main branch of the vein. And another thing is that because a smaller caliber vein drains to a larger caliber vein, the velocity increases, and it provides sort of a suctioning effect, which we also call it the Ventry effect. And we have actually published this work in plastic and reconstructive surgery, and actually have shown that the decrease in the volume of the arm is, or in the extremity that actually used the Ventry principle, was significantly faster. So by understanding the anatomy, utilizing the valve, taking smaller vein from the valve, and then making sure it drains to a larger valve, and maximizing the pressure gradient, that's the way to select the ideal vein. So here's a quick video of what the Venturi effect is. And you can see that we've connected to the side of the lymphatics, and then you could see it drain naturally into the larger vein, and having that suctioning effect allows really for the lymphatics to drain much easier to the larger vein. Another question that we had, and a lot of ambiguous evidence behind, is that there's many types of anastomosis. There is end-to-end anastomosis, end of the lymphatics to the end of the vein, side of the lymphatics to the end of the vein, side of the vein to the end of the lymphatics, and of course, side to side. So there was many types of anastomosis, but we asked ourselves, what is the best way to anastomose? And if you think about it, when you do end-to-end, you're actually causing another new obstruction distal to the anastomosis. So for us, preserving the normal lymphatic vessel and making a hole on the side and draining into the vein seemed most logical. But how can we find the evidence showing that this is the best possible way? And that was what our research was all about. We published this work and actually show that doing a side of the lymphatics to the end of the vein has a statistically significantly higher effect in terms of volume reduction. And nowadays, we're now able to provide evidence that side of the lymphatics to the end of the vein anastomosis is better compared to end-to-end. And the reason for that in our mind is because once there's an obstruction, there's a dilation of the lymphatic vessel. And when there's dilation of the lymphatic vessel, the valves also become apart. It grows apart, and the valve starts dysfunctioning. And there's a backflow forming from the more proximal lymphatics. So we're catching the backflow as well as the anterograde flow and draining into the vein. And this is why we think the side of the lymphatics to the end of the vein has a better outcome. So the significance of side to end to side LVA is it doesn't create any new obstruction. We respect the overall lymphangiosome concept, and potentially, and by decompressing the overall lymphatic system, because we're decompressing, we think that it also allows the potential to regenerate higher. And because we're doing side, it has an effect of doing two LVAs, and the number of the need for the LVA decreases. And that's our approach. I just want to quickly stray aside just 1 minute here and actually show a quick way that we do LVA. We use a special dye called fluorescein. There's many dyes that you use to identify functioning lymphatics under the microscope. In this case, fluorescein is a more yellow dye. It is not used in ophthalmology. And you can see that the lymphatics is uptaken in a yellow color. Now, why is yellow better? Because once we paint over a surgical pen, which is a blue dye, you could see that there are clear distinction between yellow and blue. And this allows us to actually have a better visualization on the edges, the margins of the lymphatic vessel, making the anastomosis much easier. So you could see after dilating the lymphatic vessel, the edges of the vessels are much clearer compared to using no dye. And this double color contrast with yellow and blue allows to clearly see the margin and makes the anastomosis easier. So I think this is the biggest evidence that we found in regards to doing LVA surgery. And because now we have the ability to actually do LVA in patients with advanced lymphedema by using the ultrasound, by able to detect functioning lymphatics, we've actually shown that even in advanced lymphedema cases such as stage 2 late or stage 3, the LVA also works as well as stage 1 or stage 2 early. And you could see that this patient with a very advanced lymphedema, of course, we did surgery and doing side to end LVA. And also we removed the fibrosis by liposuction. And she's one of the very lucky ones who was able to completely graduate from a compression and have this kind of steady result since she received the surgery. Another way to do bypass, and this is a very new idea, is doing a lymph node to vein anastomosis. Now, if you think about it, when we learn about gynecological cancer or prostate cancer for men, they're not actually removing inguinal lymph nodes. They're actually moving pelvic lymph nodes. And if you think about it, theoretically, the function of the lymphatic vessels should be intact up to the groin nodes. And what the nodes does is that the nodes collects from multiple lymphatic vessels. So theoretically, if you're able to create a bypass on the node, you're actually creating multiple bypasses for multiple, you're creating multiple lymphatic bypasses for all these vessels that drain into this single node. Now, however, we talked about this before, degeneration occurs from the obstruction, near the obstruction site, from proximal to distal. So the window of having a functional lymph node is not that long. And of course, to diagnose, to properly detect functioning lymph node is quite important. And if you look at this lymph scintigraphy here, you could see that there is no uptake in the node. But this doesn't actually mean that the nodes are functioning or not functioning. This just means that it's not reaching the lymph node in 2 hours of the exam. And if you look at the MRI, we could clearly see there's a sizable lymph node. If there's a degeneration, usually these lymph nodes shrink to a very small size. So we've actually did this early study, and then we were able to correlate that when the lymph node is larger than 0.8 centimeters, 80% of the time the nodes would be functioning. And then second, when we open and if we see ICG uptake in the node, there, it means that's clearly there is a flow all the way going to the node. And then we do a bypass on the node itself to anastomose a large superficial vein. And this type of idea, again, is not completely new. It was first started in 1968, but because they didn't have the ability to find out if the nodes were functioning or not, their early results were not that favorable as doing LVA near the inguinal region. So we modify this. Now we identify a node. Instead of cutting the node and sticking into the femoral vein, we drill a small hole on the node capsule, and we connect the vein into the node. So here's a quick example of the lymph node to vein anastomosis. First, we identify a functioning node. And then if we think the node is functioning, then we open the groin area. And usually these superficial veins are superficial to the nodes. So we identify this large superficial vein. We isolate it. And then by using the ICG, you can see that there's a clear uptake in this lymph node. So we dissect just a little part so we don't make sure that we're not injuring any lymphatic vessels going in. And then we paint it. And then we drill a small hole using a 22 gauge needle. And then we must see lymphatic fluid draining from these lymph nodes. And you could see under the ICG clearly that there's lymphatic fluid draining. And once the lymphatic fluid is draining, then we connect the superficial vein to the node. And that's creating a bypass called the lymph node to vein anastomosis. And we've reported this and clearly also shows better results, especially in early stage lymphedema. But our next question was then, how can we avoid that 20% when we open and still the node is not functioning? And this is how we started to use the ultrasound. And the ultrasound helped us to clearly identify which nodes are functioning or not. And we've created this 4 new index and ultrasound, and we actually show that it has 100% sensitivity and 100% specificity. And now we're using the ultrasound to actually map out functioning nodes, and then we're doing the surgery. So if we don't see this, then we don't do the LNVA. We're not able to do the LNVA. And of course, we do a follow-up lymph scintigraphy, and you could see in the pre-op, there is no uptake in the right groin, but in the post-op, we start to see this is the pre-op, And in the post-op, we clearly start to see a better drainage in the nodes that we connected. So this was the evidence to show that the LNVA could be also a viable option as a bypass. So what is the significance? Once the node is functioning, we are talking about large vessels, 1.5 millimeter. So you don't need special tools or special microscopes to do lymphedema surgery. You don't have to be a super microsurgeon. However, a lot of the times this is limited to relatively early stage of lymphedema as stage 1 or stage 2. And of course, this is very useful because some of the lymphatics from the genital area also drains to the groin nodes, and we're able to adequately trace and then find and then do an LNVA. And sometimes it also helps the genital lymphedema as well. And now we're doing research in the realm of doing LNVA for preventive measures. Now, the next mode of physiological approach and the evidence that we find is doing lymph node transfers. I'm not going to go into too much detail about lymph node transfers, but I am going to talk about a new concept called lymphatic tissue transfer. So in our body, remember, the lymphatics are all around, like the veins and the arteries. And there's a pathway of how the lymphatic flows. So from the umbilicus, the lymphatic, the direction of the lymphatic flow or the lymphatic vessel, the flow direction is from the umbilicus to the groin. And what we found out was that when you have these kind of post-trauma patients that have no fat at all, then all their lymphatic vessels are missing. And this is what causes lymphedema of the leg. However, when we reconstruct the defect, the traumatized zone, by aligning the fat with the flap in the direction of the lymphatic flow of the limb, we actually found out that this actually helps to regenerate lymphatic vessels and ultimately allows better drainage of the lymphedema, as you can see in this patient here. So this is something new that we are also working on, just using a fat, aligning it in the right direction, so-called the lift technique, and then we're able to enhance the regeneration of the lymphatic vessels. Another innovation, I think this is another innovation that is very important is that in the past, how do we measure or how do we objectively find improvement after surgery? And this has been very hard because for stage 1 or stage 2 early lymphedema, the major component of the swelling is fluid. So obviously, when you do a physiological reconstruction, because decrease in the fluid in the limb, the limbs also decrease. However, in advanced lymphedema patients, it's not only about fluid, it's also about fibrosis, because if the fluid remains in the fat layer for a long time, this starts to turn into scars. And even if you do improve the fluid aspect by doing a bypass, still the fibrosis aspect does not improve. And a lot of the times we do LVA in stage 3 patients, and we don't clearly see a reduced volume, although the leg becomes much more softer. So this new technology, by just measuring the water component within the designated field, allows us to exactly see whether or not the fluid accumulation has decreased after surgery. And I think this is also a very important measure to use, so-called the bioimpedance analysis, that allows us and that gives us very objective measurements of how much the fluid accumulation decreased. Finally, I think the last innovation that is clearly important in our field is that now we're able to mix the non-physiologic plus the physiologic approaches together and finally address all the components that causes swelling of the legs. In the past, we just used to focus on physiologic surgery, but now it depends on how much fibrosis or scar tissue you have, how much fluid accumulation you have, and we mix all this approach, and this kind of so-called the Barcelona cocktail approach really helps the patients to get better. Because the patient, of course, might be interested in science, but from the patient perspective, they're interested in how much improvement in terms of the limb volume is made. And in order to do that, physiologic surgery, such as bypass or flaps or lymph node transfers, are important. But in addition to that, allowing the patient to have the best possible contour by removing the fibrosis is also very important. So this kind of multi-surgical approach now, I think, is helping the patients, and I think this is also another huge innovation. So instead of now having one formula to treat the patients, now we're having various individualized formula depending on what are the components of the swelling or the lymphedema this patient has, and now we're able to address all these different components that the patient has. So in my mind, the latest innovations and the recent advances that has been made that really altered the direction of treatment for lymphedema is the imaging, allowing us to find functioning lymphatic system, and understanding the best surgical approach, such as Psi-2N, finding more evidence about Ventry effect, et cetera, and a very objective way to measure improvement, such as the bioimpedance analysis, and now the understanding of surgery, addressing each problems that the patient has with various different modalities. So where's the future of lymphatic surgery going? And this is a very, very promising future. If you think about it, 80% of our circulation is artery and vein. 20% of our body fluid is lymphatics. And we are now just starting to understand the science of a lymphatic system, a science of lymphatic surgery. And you know, we're now going into the realm of preventive lymphovenous anastomosis. And we're now seeing reports in various diseases that were closely related to the lymphatic system. I showed you a case with chylothorax, but also we're starting to operate on protein-losing enteropathy patients, venous ulcer patients as well. And hopefully we'll be able to help those patients by relieving the lymphatic pressure and allowing a better drainage of the lymphatic system. But the biggest, I think, the biggest news in the lymphatic science is that Alzheimer, dementia, has now proven to be result of decreased lymphatic drainage in the brain. So now a lot of surgeons are talking about how we're able to use this kind of idea in doing potential LVAs and potentially improving the symptoms of dementia. So this is a very interesting field. And of course, there are more adjunct treatment as well, such as this kind of non-invasive shockwave therapy that is able to improve the swelling. Multiple research has been coming out. So potentially this could be another mode for early lymphedema patients. As you can see, it increases the LYVE1, which is the cursor for the lymphatic vessels. So there's a lot of exciting new development in the field of lymphedema surgery. And of course, hopefully we'll be able to find more evidence in regards to brain dementia as well. Now, this is an ongoing science. A lot of the things are still, we don't have enough evidence, or we're in the process of gathering evidence. And in my mind, this is just the tip of the iceberg. A lot of the findings are now just over a decade or two. And of course, we need to further refine the approaches of lymphatic surgery. And this is why the robots with Simani platform is so exciting and able to deliver this surgery in the hands of any microsurgeon in the future. We're hosting a workshop for the professionals who are interested in October at Asan Medical Center in Seoul. This is where I work. And hopefully I'll be able to see a lot of you there. So that is basically my presentation for today, sharing some of the latest innovation and the evidence in lymphedema surgery. And now I'm going to be going into the Q&A and hopefully able to address some of the questions that the participants raised today. So this is a very good question. Here we go. And this is from Kristen. Can you please talk about longer-term outcomes for lower limb primary lymphedema patients? Wow, I could give a 2-hour talk on primary lymphedema, and at the end of the talk, I think what I would say is we still don't know a lot about primary lymphedema. First of all, what we know is that what we vaguely know about primary lymphedema is that it has a completely different pathogenesis than secondary lymphedema. We think some of the patients, it's a problem of lack of lymphatic vessel formation. And we think some patients with primary lymphedema is a lack of function. And in some types of primary lymphedema, it's a combination of both. So in cases where the lymphatic vessels are functioning, but it's a lack of function, by doing lymphovenous bypass, we've actually seen cases that has pretty good result. But if it's a problem with formation and the lymphatic vessel itself is limited and undergoes early degeneration, then the possibility for a physiological approach becomes very, very low. And even if we're able to do LVA, I think in our hands, we do see volume decrease in 60 to 70% of the patients that we operated after identifying functioning lymphatic vessels. So we do see good response. However, I was only able to see one patient that came very early when she was 4-year-old, and she completely weaned off from garments, from pressure garments. I think it's because we were lucky enough to operate on her because the degeneration process was still relatively early, and I think we were able to help her. So in my mind, I think if you have primary lymphedema and you've passed a certain stage or age, that the degeneration is so severe that whatever we do, it's not going to help much. So the longer outcomes are probably will be very, very difficult. However, in my mind, if we're able to approach primary lymphedema early, in early stage of the disease or relatively early age, I think we'll be able to see better outcome. Now, that being said, I think the outcome that I'm talking about here is from 5 to 10 years. And we don't really know further down the road because this surgery, again, has been around for a decade or two. But what we do know now is that early intervention, even for primary lymphedema, there is a potential for a long-lasting result. So I hope I was able to help you understand your question. So let's another question here is how long has this surgery been around? And like I said, you know, the idea or the approach for humans has been tried since the 70s. However, now with better understanding, better technology, better tools, now it started to just take off in a decade or two. Dr. Kushima from Japan started this surgery in the late 90s, in the early 2000s, and he is considered as one of the pioneers in modern lymphedema surgery. And slowly, it's still at the phase where it's gaining momentum. So I'm sorry to say that not even a lot of professionals know a lot about availability about this lymphedema surgery. So hopefully this will be more popularized in the upcoming years. However, in the US, there are multiple centers that are doing lymphedema surgery, and I think you have to search which centers has this available and seek a consultation there. Another question is, how do you choose the recipient vein for lower limb edema in patient who has varicose veins? This is also a very good question. And additionally, she asked, what about if you had a surgery or stripping of the superficial veins? This is a very good question. This is why we always like to evaluate the vein system as well, using a CT venogram and make sure the superficial vein is working. Now, if the superficial vein is missing or is obstructed in a way that it will not have a normal functioning capability, in this case, we go to the deep venous system. And we go underneath the deep fascia, find the deep vein, and then we try to utilize this deep vein and hook it up to the lymphatic vessel. But this kind of case, again, is not that common. Although some part of the vein may be missing, the vein also is like a link, multiple collaterals. And as long as the vein branch that I'm using is draining to some major vein, then I think it is usable. Thank you for your question. I think I mentioned this briefly. This was another repeat question. Is this surgery applicable for primary lymphedema? And the answer is yes, as long as you find functioning lymphatics using ICG and the ultra-high frequency ultrasound. I think we still have to gather more data, and hopefully we'll be able to have a more clear idea on what are the response rate and what are the long-term outcomes as well. Another question is, can LVA and lipo be done at the same time? We do, but we do it in a way that basically we know the anatomical pathway of the common tract of how the lymphatic flows. And in these regions, we try to avoid doing liposuction if we're doing a one-stage approach with lipo and LVA. In these cases, what we will do is we'll avoid that high density area of where the lymphatic vessels are and try to remove the fat in areas of known lower density of lymphatic vessels. So to answer your question, it can be done. The reason why I'm laughing is one of the questions is, who are the best surgeons in the United States to see for super microsurgery? And I think the best answer would be go to the LE&RN homepage, and I think you'll see multiple data and surgeons doing interviews and a previous presentation as well. And I think the answer could be more clear, and the reference could be better by looking into the LE&RN homepage, and I think that would be quite useful. Would you recommend the patient undergo lymphedema reduction through CDT before undergoing surgery? Yes, for sure. Nowadays, we always do a multidisciplinary approach. Acute lymphedema. So the patients who recently underwent cancer surgery, for example, the arm or the leg, and just start to have lymphedema, the great news is that 80% of these lymphedema with the right compression therapy, 80% of patients will get well, and they don't need surgical approaches at all. So we always start, especially for acute lymphedema patients, we always start with compression. And when this doesn't work for a certain period of time or under special circumstances, then we consider doing a surgery. So to answer your question is, yes, I think it's a very important protocol that you undergo compression therapy before you seek surgical therapy. How does one start to find out if they're a candidate to have this procedure? Again, first, you must have a clear diagnosis whether or not you have a lymphedema. And one of the ways to do clear diagnosis is, of course, you have to see a specialist, and the specialist needs to prescribe you or to prescribe you a test called lymphscintigraphy. Lymphscintigraphy is a radioisotope study that actually sees the overall flow of the lymphatics. And if this overall flow is decreased, it was in one of my slides, then you are diagnosed as lymphedema patient. And after undergoing compression therapy, if you are indicated, then you might be referred to the surgeon. So you have to go see a professional lymphedema specialist, and then undergo diagnosis with radiologic imaging studies, and then and once you have the diagnosis, you can be considered a candidate for surgery if the compression doesn't work. All right. So I think I'm at the last drops of the questions. Here's another question. Are you using BioBridge for LVA? I have read about this and spoke with a patient who had this done. And the answer is yes. The way BioBridge works is it's a special scaffold that allows better regeneration of the lymphatic vessel. However, the BioBridge must be connected to a lymph node. And that's why the regeneration of the lymphatic vessel, when it happens, it drains into the node. So as long as you have a functional lymph node and you connect the BioBridge, then I think it will allow to allow the patient to have a better recovery. So yes, we are using BioBridge. There's multiple references out there, so read about it. And again, there are some surgical tips and tricks, but to answer your question, we are using. There's another question. Over time, can LVA and LN lymph node transfer decrease the function or even fail? This is a very interesting question, and the honest answer is we don't have scientific evidence to give you a definite answer. But I will give you what I think. So if you do an LVA, how does it work? It works with a pressure gradient. The high pressure lymphatics drains to a low pressure vein. But theoretically, as it improves, the lymphatic pressure will drop to a level of the vein. And when that happens, there's a pressure equilibrium, and then the flow, because lymphatics is dynamic, it's a dynamic system. When you walk, it will work, and when you're steady, it will work less. So in my mind, because this occurs in a dynamic organ, I don't think it really stops functioning. However, what I think is why then some people recur is because there's an increase in formation. For example, the patient may get obese and starts creating more lymphatic fluid, and then will overgrow the current capacity of the surgery. So I think in that terms, then you might have to do another LVA. So, or a lymph node transfer, which the lymph node transfer, I think, works in the same way. So just because you did the surgery, it doesn't mean that you'll have zero chance of recurrence. I think lymphedema, like I said in the beginning, there is no cure. And as a patient, you must take care of yourself, identify the risk, understand the risk of having a lymphedema, and try to manage those risk factors. And one of those risk factors being obesity. So I think staying healthy. Also, when you see early signs of swelling again, wearing compression, going back to compression, doing massaging, and I think will help to address this issue. Okay, the final question is, and really thank you for all your questions again. And a lot of the questions are overlapping. And I really appreciate all the great comments that you gave me. And hopefully we'll be able to do a follow-up presentation in the near future as well. Here's a question. Hi, I'm a therapist. I'm a massage therapist, and I've seen a lot of patients struggle, and I don't see the problem getting addressed effectively by their doctors. So, and I think, like I said, I cannot emphasize the importance of conventional therapy, such as compression and massaging, lymphatic drainage. So everything needs to be adjunct to each other. And this is why you need to have a good team, or at least a good alliance with the surgeons. And if you're referring to a surgeon, then you have to make sure that the patient is referred back to you and continue the treatment. Because I don't think because you had the surgery, you're not going to have conventional therapy at all. So it is very important that the patients know that getting a surgery is not a cure-all. After you do the surgery, it takes a certain time, months, even years to get better. And during that time, conventional therapy such as compression and massaging is very, very important. Okay, one final question I'm going to answer, and I want to stay in time, is there any surgical intervention for filariasis? And for those who don't know what filariasis is, it's a sort of like a parasite that lives in the lymphatic system. I do believe it's transferred by insect bites, such as mosquitoes. And again, it's a concept. It's the same concept. It's a concept of obstruction. So if you go distal to the obstruction and create a bypass, theoretically, it should work. And I've gone to India to do surgeries on filariasis patients. And of course, I was staying there 1 week, sharing sharing and educating about this technique. And I have not been there to see the follow-up of many years. But the surgeons that learned and is now doing LVA has told me that it works quite well in patients with filariasis as long as you're doing the bypass distal to the obstruction point. So to answer your questions, I do think it's the same concept and it should work in patients with filariasis as well. Okay, so thank you so much, everybody, for taking part in this LE&RN seminar. And I really want to thank the LE&RN faculty for inviting me to present some of the work that I've been doing and some of the evidence that I was able to provide in the last 15 years of doing lymphedema surgery, almost 20 years of doing lymphedema surgery myself. It's an exciting field. And I think the most exciting part about doing lymphedema surgery is that now we're able to provide a glimpse of hope for patients that had really no solution other than conventional therapy or very aggressive debulking surgery in the past. And I'm very also happy that as we learn about the lymphatic system, hopefully we'll be able to find solutions for even disease that were once thought not solvable, such as lymphedema. So I think with that, I think I'll sum up. I'll sum up this presentation. And again, I thank you all for your great questions and taking part. Thank you.